Good afternoon, ladies and gentlemen. It's my great pleasure to be in Cleveland and to have this opportunity to talk to you about this new and emerging area. I'm told the screen will flip to and from the Cleveland's game in basketball. That's perfectly fine by me. We do that all the time when there's a big hockey game on. So I'm going to be talking about this 1433 mediator, which is capturing some attention, not just in rheumatoid arthritis, but also in spondyloarthritis. And I think maybe even President Obama has heard about biomarkers because we've heard of the term precision medicine. And I think this is what leads us to become somewhat more interested in how we might optimize the management, the evaluation, and management of patients with rheumatoid arthritis. When I think of precision medicine, and as a clinician, when I think of the questions that I would want a biomarker or a biomarker strategy to address, these are the sorts of things that I'm thinking about in the clinic. I see patients every day presenting with a polyarthralgia, and they'll have a suggestive history of inflammatory joint disease. And I really would like to know with a high degree of precision whether these are patients destined to develop an inflammatory arthritis so that I can intervene early and perhaps even induce a change in the natural history of their disease. That's an important objective. In addition, when patients present with a full-blown arthritis, I also want to understand something about the optimal treatment strategy to prevent joint damage, which patients, which drugs, and early intervention to prevent functional progression. So this risk stratification is another important strategy. And then thirdly, knowing exactly which treatments should be instituted to begin with. So these, I think, are the key questions that go through my mind when I think about precision medicine. And I think it's fair to say that if we think about 2015, our treatments work well, but not our prediction models, especially at the level of individual patients. I think we struggle with these questions in day-to-day clinical practice. We've gone somewhere towards addressing these questions in clinical research by reappraisal of the classification criteria. So we now want to capture earlier categories of patients with rheumatoid arthritis, for instance, as well as spondyloarthritis. The new classification criteria aim to capture a broader proportion of the spectrum of patients. We also recognize as we do this that our existing technologies, our existing biomarker platforms are inadequate, not only in terms of their specificity, but also their sensitivity. Here's one of my favorite slides. This is from the Leiden cohort, which illustrates how much do we know about the predictors of radiographic progression over a period of 5 years in patients presenting with early rheumatoid arthritis. And if we look at that, this pie chart, you'll see that our existing predictors only account for about a third of the total variance in the risk for radiographic progression over 5 years. So there's a lot that we don't know about the predictors of radiographic progression. So that is, I think, the challenge for biomarker development, for biomarker platforms. And 1433 is an interesting mediator that I'm going to discuss. Many of you will be unfamiliar with 1433. We haven't heard a lot about this interesting group of proteins. There are 7 isoforms of 1433. And these proteins are typically intracellular and are crucial for a variety of cellular functions. The specific isoform that I'm going to discuss shortly will be the ETA isoform, and this displays a high degree of homology with mouse and rat. Now, how do we come across 1433 ETA, and why is it of interest in arthritis? So this was somewhat serendipitous in terms of its relationship to arthritis, but one of my colleagues, Dr. Aziz Gahari, have been interested in the factors that regulate metalloproteinase production in keratinocytes. And we were quite interested in exploring what these factors might be in patients with arthritis, because, of course, metalloproteinase expression is such a key step in the development of joint damage. And what was interesting when we did these simple Western blots was that one specific isoform, the ETA isoform, to a slight degree the gamma isoform, but it was almost entirely the ETA isoform, is what was found in the joints of patients with inflammatory arthritis, and also in the peripheral blood, but it was present at least fivefold greater concentration in the synovial fluid. And then, of course, the first thing that we wanted to do was to see whether there was a relationship with metalloproteinase expression, and this was evident in both synovial fluid and in the peripheral serum. And as we try to understand more about the biology of this mediator and how it might be involved in arthritis, we asked several important questions. We wanted to know something about the signaling cascades that were activated by 1433 ETA and the mediators that were expressed on exposure to 1433 ETA. So it was typically, as I mentioned, these proteins are intracellular, and for reasons that we still don't understand, 1433 ETA is expressed extracellularly. So we wanted to know what the consequences of that expression might be and whether we could attenuate the effects with antibodies. So our initial cell stimulation experiments were conducted in a variety of cell lines, and using concentrations that, as I'll show you shortly, are observed in patients with rheumatoid arthritis. So I'm going to talk about a concentration of 12.5 nanograms, but as I'll show you later, we see effects with much lower concentrations than this. And we looked at the phosphorylation of a variety of targets in different cell signaling pathways. And here's an example of what we saw with respect to the activation of and phosphorylation of signaling mediators in different cell lines. So we see that monocytic cell lines, particularly THP1 cells, are highly responsive to 1433 ETA. Similarly, myeloid and fibroblast cell lines, but not T cells or B cells. And then when we looked at a variety of signaling pathways that are really quite germane to rheumatoid arthritis, we see again that very soon after incubation with 1433 ETA, and this is actually a comparison with TNF, similar concentration of TNF, see the phosphorylation of mediators and transcriptional factors in a variety of signaling cascades, but not the P38 MAP kinase or the NF-kappa B pathway. In that respect, 1433 is different from TNF-alpha. So then we looked at a variety of cytokines, rank ligand, metalloproteinases, to see which might be expressed following incubation with 1433 at the sorts of levels that we see in patients with rheumatoid arthritis. And what we see is that, again, comparison with TNF-alpha in this slide, We see there are a variety of inflammatory cytokines, IL-1, IL-6, IL-8, MMP1 and 9, rank ligand, and even TNF-alpha are all expressed and upregulated on exposure to 1433 eta. Not all inflammatory mediators, for example, metalloproteinase 2 is not upregulated by 1433 eta, unlike TNF-alpha. And so when we look at these dose-response analyses, and we see now we're getting to really quite low concentrations here, so 0.1 to 1 nanogram per mil. This is well within the median concentration, 1433 eta, in our RA population is around 1. We already see IL-1 beta is being expressed, and IL-8 and MMP9. So there's expression of factors relevant to the pathogenesis of RA, very low concentrations. There's clearly a hierarchy going from some factors down to others. But there's clearly expression at very low levels of this mediator. And yes, the expression, for example, MMP9, can be inhibited by incubation of antibodies to 1433 eta. Now these are, what I'm showing you on this slide now is the results of co-culture experiments. This is a expression of a variety of factors relevant to the pathogenesis of rheumatoid arthritis. And one can analyze what the pattern of cytokines might be in a variety of co-culture models. In this case, for example, I'm showing you a co-culture model with B cells and peripheral blood mononuclear cells. And what we see here is that in this co-culture system, we see an upregulation of IL-17 and IL-6. So there's further clues as to how 1433 might work in co-culture systems relevant to rheumatoid arthritis. This is, I think this slide summarizes where we currently stand with our understanding of the biology of 1433 eta. We think 1433 eta is secreted from exosomes, and in the extracellular environment, it interacts with its ligand. What that ligand might be at this point, we're not sure of. We suspect it may be a toll receptor ligand, but we're not clear about that at this point. And a variety of cell signaling cascades are activated. Not all that we see, for example, with TNF, not P38 or NF-kappa B pathways. And this then culminates in the transcriptional upregulation of a variety of cytokines and joint damage factors such as rank ligand and metalloproteinases. So this activator, this mediator, seems to be particularly relevant to cells of the innate immune system, monocytes, myeloid cells, not B or T cells. There isn't direct activation of B or T cells. And this seems to be an important mechanism whereby 1433 might induce inflammation in rheumatoid arthritis. Now, one of the further developments as we've explored this biomarker platform is that 1433 eta does induce the expression of antibodies to the native protein. And in addition, because it's expressed at the site of disease, perhaps not surprisingly, there are arginine residues that are citrulinated. And so we see antibodies developing to the citrulinated modified version of the 1433 eta protein. So the protein is composed of 9 alpha helices, and homo-heterodimers form this antigen, or ligand, I should say, binding groove. And you can raise antibodies to a variety of peptides that are found in the location of this groove. And these are the antibodies that we've explored in some preliminary studies that I'm going to mention shortly. A few things about the assay that I think are very important, and certainly very important as far as clinical validation is concerned. We certainly want a stable biomarker platform. We don't want a biomarker that is labile, particularly under the conditions of clinical practice. And this seems to be a very stable biomarker with very similar concentrations after repeated freeze-thaw cycles. It's not impacted by the kind of interference substances we might see in the serum, for example, monoclonal antibodies or rheumatoid factor. And we haven't seen significant correlations with age, as you might expect with metalloproteinases, or gender, again with metalloproteinases, or ethnicity. Now, these are the baseline characteristics of the patient cohort that we describe in the Journal of Rheumatology manuscript. And there's a group of patients with early rheumatoid arthritis. You can see a very short disease duration of just over 3 months. And then a category of patients with established rheumatoid arthritis. And these are, as I mentioned to you earlier, these are the median concentrations. And this gives you an overview of the levels that we see in patients with early as well as established rheumatoid arthritis. Then almost 400 controls, which are comprised of healthy individuals and patients with a variety of other arthropathies such as gout and ankylosing spondylitis. They're referring here to the protein, not to the antibodies at this point. There seems to be a little bit of a blip in psoriatic arthritis. There's some very preliminary, I want to emphasize that term, preliminary data that patients with psoriatic arthritis and erosive disease, there may be elevated levels of this biomarker in those patients. That's just 24 patients, as you can see. So that's just still preliminary data. We don't really see very much in osteoarthritis, but again, the numbers there are somewhat limited. If we look at the traditional parameters, the sensitivity and the specificity in early rheumatoid arthritis, and the data here in terms of area under the curve and the likelihood ratios, the sensitivity, specificity data, very similar irrespective of the control population. You can see that the disease duration really is very short in these cohorts, 3 separate cohorts, and the data was pooled because they're very similar baseline characteristics. So there is a sensitivity of around 64% and a specificity of around 93%. I think this is the slide that is particularly relevant to clinicians. What we really want to know is how much does 1433 add to what we already know from the assessment of ACPA and or rheumatoid factor. And so see that there is an incremental increase as we go from single biomarker assays, for example, rheumatoid factor at 56% detection of early rheumatoid arthritis. And when we look at all 3 biomarkers, any one of those 3 being positive, see detection rate of 77 in early rheumatoid arthritis. What about correlations with existing biomarkers, those that are commonly used in clinical practice, for example, SED rate, C-reactive protein, ACPA, rheumatoid factor? So this is a correlation matrix that tells us something about the correlations. The first thing you'll see is that there's very little correlation with acute phase reactants. I think we're really quite confident about this observation in larger data sets. We are being informed about something other than processes that drive elevated acute phase reactants. There is a correlation with ACPA and also with rheumatoid factor, but not with acute phase proteins. And in fact, there is some quite interesting data, I think, in patients who are CRP normal. You can see that over half the patients, 65% of CRP normal patients, are positive for 1433 ETA in this fairly large Dutch cohort of patients with early rheumatoid arthritis. And the question is, what does that mean? What's the clinical significance of that? Well, there is some preliminary evidence now emerging that such patients, i.e. CRP normal, but with positive 1433 ETA, these patients have a higher level of radiographic progression. I forgot to mention earlier that the cutoff for diagnostic usage is 0.19 nanograms per ml. So that concentration is the diagnostic cutoff. So when we look at patients who are positive at that cutoff and CRP normal, we see that there is evidence of more radiographic progression in this cohort at year 1. These patients, this category of patients who are 1433 ETA positive according to that cutoff, also have more significant, more severe disease according to the traditional parameters such as the DAS, the HAC. Acute phase reactants are higher, so it designates a more severe category of rheumatoid arthritis. Now, one of the factors that I think, or one of the properties of the biomarker that I think are desirable, are that it should be modifiable, because what we would like to see is a biomarker that informs us as to prognostic risk when you've intervened with the treatment. So typically, you'll see a patient, you'll assess the biomarker, you'll give the patient a treatment, and what you hope is that the biomarker normalizes. And that then gives you some measure of confidence that that patient's disease is under good control, is not likely to progress to severe joint damage. It's this modifiability that I think is an important characteristic of a biomarker for use in clinical practice. And we have evidence that 1433 is in fact modifiable with a variety of therapies, including anti-TNF therapies and IL-6 directed therapies. Perhaps not surprising in view of what I showed you earlier in those co-stimulation experiments. We also see a decrease in 1433 after the use of standard DMARD therapies. And this change is of prognostic significance. In other words, these are patients who are more likely to have a good EULAR response if levels decrease with treatment. So in summary, 1433 is significantly higher in early and established rheumatoid arthritis. There's evidence that it's complementary in terms of its clinical properties with rheumatoid factor and ACPA. It identifies a more severe category of rheumatoid arthritis, and it really seems to tell us something different from acute phase reactants. And the way that I've started to think about this biomarker is that it seems to behave as a modifiable prognostic risk factor. It's telling us something about the risk for damage and disease severity. But unlike ACPA, it's modifiable with treatment. And go back to the summary here. It activates a variety of signaling cascades relevant to the pathogenesis of rheumatoid arthritis. And what's interesting is that is this expression, this extracellular expression that we see in specifically in rheumatoid arthritis. Now, I just wanted to give you some information, some very recent information now about where we're going in terms of the further development of this biomarker platform. So as I mentioned earlier, the protein induces the production of antibodies to the native protein. And there's very little correlation, despite that, there's very little correlation between levels of the protein and levels of the antibody. And so the antibody seems to be telling us something different about the disease. And in fact, when we look at the combination of the protein and the antibody in an early rheumatoid arthritis cohort, we see that this detects almost 90% of patients with early rheumatoid arthritis. When we combine that with ACPA and rheumatoid factor, in other words, if we had a platform of these 4 biomarkers and we were to say, well, if any one of those biomarkers is positive, what proportion of the early RA population are we capturing? It's almost 95% with all 4 biomarkers in the platform. So we've become quite interested in the fact that this antibody is also found in early rheumatoid arthritis. You can see 73%. Interestingly, it diminishes as the disease develops because in established rheumatoid arthritis, the percentage positivity is much lower at 15%. But in early rheumatoid arthritis, there's a much higher proportion of patients who are positive for the antibody. So the biomarker platform is not just about the protein, it's also about the antibody to the native protein. And similarly, we have some evidence emerging now that antibodies to the citrulline protein also detect a different category of patients from those who are just positive for the protein. And this is one other direction that I think is becoming interesting that we're exploring at this point in time, and that's trying to understand how the combinations of these biomarkers might work to inform us about prognostic risk. So what we see here is the development of radiographic progression as measured by the total Sharp score over time out to year 5. And what we're comparing here is categories of patients who are just positive for the antibody to the native protein versus those who are positive for both the antibody and the protein. And we can see here that there's some evidence that the antibody may act in a protective manner, whilst the concomitant presence of the protein is a severity factor, is a prognostic risk factor. So when you have the protein, this suggests that this earmarks the patient for a more severe trajectory of disease. Whilst those patients who are just antibody positive, they may be relatively protected from the development of radiographic progression. So that's a summary of where we're going, and the first manuscript describing the antibody has just been accepted for publication and hopefully should be coming out very shortly. So I'd be happy now to ask any questions that you might have. Thank you very much.
Thank you, Walter. It was outstanding. I have a bunch of questions, but I will hold mine. Open this up for questions. Ritu?
Excellent presentation, Doctor.
Thank you.
My one question is, as you showed, with purified eta protein, there is an induction
No, we haven't looked at any of the isoforms.
Can I just repeat this again, so so everybody gets this, that's listening in, that the ADA isoform is an inducer of phosphorylated stat, and Ritu asks whether any other isoforms of 1433 act as in a similar fashion.
We don't know the answer to that, but in arthritis and inflammatory arthritis, we haven't really seen any other isoforms. So we haven't, there was a little bit of gamma, but really when we look at the mass spec analysis, it's really 1433 eta. And so we really haven't explored any of that. They don't seem to be expressed extracellularly, they're all intracellular. So we haven't really explored that question.
Dr. Hoffman.
Thank you, Walter. I really enjoyed that. The observation of the antibody being much lower titers in patients with established disease versus early onset, that doesn't tell us anything about their disease activity, the early group versus the established. Could it be that the established patients were on treatment and their disease activity was less?
I think that's certainly possible. It's we don't really know a great deal about the modifiability of the antibody at this point with treatment. So it's certainly possible that just like we see with our current aggressive treatment strategies, that the treatment is having a confounding effect on the assessment of the antibody. The patients of early rheumatoid arthritis are all, serum was taken, patients are all very active. So from the COBRA cohort and the TEACH cohort. So all those patients baseline are really quite active. But it's quite possible, yes, that with us sampling at a cross-sectional level, we haven't really done serial assessments over time to see to what degree. But we don't really see good correlations with disease activity parameters at a cross-sectional level.
I'm going to follow up with a question. I'm particularly interested in the antibody question. So the fact that there's a higher prevalence of antibody early, lower prevalence late in the course of the disease raises methodologic questions. And I know you didn't have time to talk about your methodology, but so the assay that you're using for antibody, is it capable of detecting free antibody, antibody in immune complex? Have you looked at any type of pH shift assay to see whether this is bound and that's doing this, or what's your thinking?
So the antibody assay is based on those peptides. So the peptides that are found in the antigen binding groove. So to go beyond that and address some of the questions that you've raised, I don't think we could address any of those questions at this point. I mean, there's a lot of things that could be happening. I mean, it could be tolerance, some kind of tolerance to the protein. That the type of antibody that's being produced could be very different. There's a lot of different things that could be happening. There could be modifications to the protein that we don't know about. So there's a lot of different things that are happening. We're simply not detecting the antibody with those specific peptide-based assays.
Question. Ritu?
Do you know the source of this protein? What cell types are expressing it, and what is the reason why they're expressing it so much?
So we have evidence that it's present in at least two types of cells. One is the chondrocyte, and the other is the fibroblast, and in fibroblast exosomes. What triggers the expression is something that we're working on at this point.
Just to follow up on that. So the fact that this is extracellular in these settings, any other notion of, and it seems to act as an alarmin of sorts in the innate immunity. Is there any evidence that any of these have antimicrobial properties or anything like that? Has that been examined as an ABP?
No, but I think that the notion that this might be an important mediator in innate immunity, an early warning sort of mechanism for induction of inflammation, development of the innate immune response. I think that really does resonate. And I think that could account for why we might see this antibody developing in early disease. So normally, the immune system doesn't see this protein, and we see the antibody response developing in quite early disease because of the exposure to this inflammatory mediator. But I think it's perhaps telling us something about its role in innate immunity.
We look at extra-articular manifestations and association with this antibody or even protein?
We don't have a lot of patients with extra-articular manifestations anymore. I don't think we can specifically, I mean, things like nodules and vasculitis and
Sjogren that comes with rheumatoid, irritability.
I don't think we don't have a very large body of data for systemic connective tissue diseases, but and we don't have a lot of rheumatoid arthritis patients anymore with extra-articular manifestations is the problem. So I don't think I could answer that question definitively, but we don't seem to see elevated levels in other systemic connective tissue diseases, scleroderma, lupus, and so on.
Marina?
Walter, you showed us that it affects matrix metalloproteinase 1 and not MMP2.
Yeah,
We know MMP1, the origin is synovium, and MMP2 is mostly chondrocytes.
yeah.
Do you think it will have any role in spondylo then? Because if it's mostly a synovial marker,
Yeah.
like in an axial spondylo.
Yeah. So we don't see the protein in spondyloarthritis. We had some preliminary data with this preliminary peptide-based assay that the antibody is seen in patients with SPA, and that the antibody does relate to inflammation in SPA. And actually, this is what I might have predicted based on the discussion we've already had about innate immunity and the role of innate immunity in spondyloarthritis and the cell types that are activated, the pattern of cytokine expression, and so on. And so we do see the antibody, and it's actually quite a few of the peptide-based antibodies in patients with SPA, related to MRI inflammation and also related to radiographic progression in SPA. So that's still, I want to emphasize again, preliminary. It's based on those peptide-based assays. But I think it suggests that this is a mediator that may have a role in other inflammatory joint diseases.
Me too. You get another one.
Yeah, thank you very much. I'm just curious to know some detail about the protein 3,3 eta experiment, because when you put the purified protein, was that protein purified with the bacterial system or with the mammalian system? Because that will reflect the signaling induced by this protein has any modification which is related to only mammalian systems
Yeah.
or bacterial systems. So just
Yeah.
little detail on that.
So when you look at the pattern of, I mean, I think what you're getting at is whether there's sort of contamination, and you may. No?
The source of the eta protein that you tested in your experiments.
So you're not talking about the assay. Okay, so the source of the protein. I'm sorry, could you elaborate that question again? I'm not sure I understand what you're getting at.
So the protein that you used to induce the signaling, was it purified from the bacterial source or say recombinant using CHO cells or any other mammalians?
Recombinant. Yeah.
Virus expression system.
Yeah. Recombinant.
Recombinant
Yeah.
using bacteria?
Yes.
Other questions or comments? Just the peptide-based assay that you're using, is
Yeah.
it a solid phase? Is this a pull-down assay, or do you?
It's an ELISA. Yeah.
I want to thank you for this visit, very enlightening talk about this system that, just a great evolving story, and, you know, we're all staying tuned. So thank you again.
Thank you.